Hi everyone, and welcome to the Otolaryngologic Clinics podcast. I'm Jessica McCool, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles centered on a central topic. Today, we will be discussing the February 2018 issue on congenital vascular lesions of the head and neck. Here now is consulting editor Dr. Sujana Chandrasekhar to lead the discussion with issue guest editors Drs. Teresa O. and Milton Weiner.
Hello, I'm Sujana Chandrasekhar, consulting editor for Otolaryngologic Clinics of North America. Today I'm speaking with Drs. Teresa O. and Milton Weiner, who are guest editors of the February 2018 edition of Clinics on congenital vascular lesions of the head and neck. Dr. O came to otolaryngology and facial plastics via a master's degree in architecture, and she is currently the director for the Facial Nerve Center, New York Facial Paralysis, and a principal surgeon at the Vascular Birthmark Institute of New York. Dr. Weiner is the director of the Vascular Birthmark Institute of New York and an internationally recognized authority on vascular anomalies. Teresa and Milton, I'm really happy that you're able to speak with me about this issue of Clinics. As I said in my foreword, the problem that your issue is teaching us about affects 1 in 10 children, and this vascular anomaly is visible on every picture to every visitor, often the first topic with the new parents, adding to the stress of having a new baby. I really like the way you organize the topics in this edition of Clinics because I think it really helps the physician and the team understand and explain options. So let's give our listeners a brief highlight of the treasures they will find inside. In the first article, Dr. Paula North writes about classification and pathology. And obviously, without knowing this correctly, it's really impossible to treat the patient properly. This article is jam-packed with information, and I'd like to just highlight 2 points, if that's okay. Teresa, Dr. O, what's the significance of the GLUT1 marker? And then how important is the distinction between macrocystic and microcystic lymphatic malformations?
Hi, Sujana. Well, GLUT1 is a glucose transporter protein which is found on vascular endothelial cells. It's important because it's only expressed in infantile hemangioma. Other types of vascular tumors or malformations do not express this marker, so it's very unique. And this was a landmark discovery by Paula North, Marty Mim, and Milton Weiner in 2000. Regarding your second question about lymphatic malformations, the distinction between microcystic and macrocystic LMs is really important to a certain extent. Macrocystic lesions refer to cysts which are greater than 2 centimeters in size and are typically unilocular. These can be treated with sclero or surgery and can also be curable. Microcystic lymphatic malformations, on the other hand, are typically more extensive, infiltrate the tissues and the tissue planes. These types of lesions most often require serial multimodal treatments and are much more difficult to treat. The more important distinction for treatment and outcome is really whether the lesion is focal or diffuse. Focal or solitary lesions involve one subsite and can be essentially cured with sclero or surgery, whereas diffuse lesions involve many subsites, need a multidisciplinary approach, and usually require ongoing therapy. In other words, it's much more difficult to cure these.
Interesting. I have to say to our readers, the histology pictures in this article are really terrific. And especially if you're working with pathologists who may not be exposed to these kind of tumors frequently, I think it's well worth sharing with your pathologist. Moving onwards, parents will always ask why. Why did this happen to their child? Why? What can they do to prevent it perhaps in future children? In their article on etiology and genetics, Drs. Quaser, Boone, and Vikula try to help us understand why and understand how to counsel. So Milton, Dr. Weiner, what is the significance of finding the various genetic abnormalities underlying congenital vascular malformations?
Hi, Sujana. Well, this is a field that just recently exploded. Prior to this, we didn't have a clue. We did not understand. We knew that some of these lesions, very few of these lesions, were inherited. We understood that there was probably some genetic abnormality, but we didn't really understand what these abnormalities are. Now with the work, especially the work done by Mika Vicula and Laurence Boone, we're beginning to understand the different pathways. And essentially there are two pathways. One pathway leads to venous malformations and lymphatic malformations, and the other pathway leads to arteriovenous malformations. And you ask, what is the significance? Well, as we're discovering these pathways and these genetic abnormalities, we will be able to find drugs that target specific pathways. So, for instance, we use rapamycin on a lot of patients. Rapamycin is a drug which targets specifically the mTOR pathway, which is really the mammalian target for rapamycin. And so the significance is that as we find these genetic abnormalities, there are certain drugs that can target specific abnormalities or specific pathways, sirolimus, rapamycin, and a whole host of new drugs. And in fact, interestingly, Teresa's working on some very, very innovative research, which is looking at using two drugs which target two different areas along the pathway towards arteriovenous malformations. So the significance, in short, is that as we understand the genetic abnormalities, we'll be able to use drugs to target specific pathways. And I think in about 100 years from now, people will say, you know what? 100 years ago, they used to excise these lesions. I mean, have you ever heard of anything so ridiculous? So we're eventually going to put ourselves out of work, but that's the progress of science.
Of course, always looking to enhance our obsolescence, right? I think as we go forward, we always, the difficulty with these cases is that these are in children. And you obviously want to streamline the care of children. You want to minimize imaging, minimize both radiation exposure and just the fear factor of having repeated imaging and maybe even sedation. But we do need the right amount of information before we intervene. So in their article on the imaging of these lesions, Drs. Steinklein and Schatzkis highlight what's appropriate and when. And I really, for our listeners, there are some really table 1 and table 2 in the third article in the clinics that we're talking about is really nice. Looks at ultrasound, CT, MR, and angiography, and what are the major imaging features to look for. So, Teresa, I was wondering if you could tell us, just to pick one topic out, the differentiation of Sturge-Weber syndrome from a simple port wine stain is really important. So how and when is this best done?
Well, first of all, port wine stains or capillary malformations on the face follow dermatomal patterns. And patients with stains in the V1 forehead or V2 maxillary or combined V1 and V2 have a risk of meningeal and ocular involvement. Any intracranial involvement can lead to seizures and cognitive issues. And if they have this, we call it Sturge-Weber syndrome. So we want to diagnose this early to prevent any brain or vision problems. Babies will get screening MRIs by age 1 or 2. And if there's any evidence of brain involvement, we'll refer that patient to a pediatric neurologist. There are also specialty pediatric neurologists who deal solely with Sturge-Weber. It's also important to note that even at age 1, there are some subtle brain changes that may be missed on MRI, and a child may need further imaging at 1 or 2 years later. So children do need to be screened by pediatric ophthalmology to rule out any ocular involvement because untreated, this can lead to blindness.
That's really interesting. And again, similar to the pathology in the first article, I think the radiographic images in this one are extraordinary. And again, something to be shared with our radiology colleagues, particularly if we're practicing in areas not in centers where this is not seen very frequently. I think as we move forward, let's talk about something that's common, which is infantile hemangioma. It's the most common benign vascular tumor of infancy. Dr. Adams and Ricci have given us a lot of useful information on how to assess and treat these lesions. So, Milt, Dr. Weiner, is a focal lesion that continues to proliferate after 18 months of age likely to be a hemangioma?
Okay, Sujana, the short answer is no. Focal hemangiomas proliferate for the first, or rapidly proliferate rather, in the first few weeks of life, and by about 9 months, 10 months of age, they should really stop proliferating. If a lesion is continuing to grow beyond this time, one should very, very, very seriously consider that this is an angiosarcoma or some other lesion other than a hemangioma. And in children, every now and again, unfortunately, we see angiosarcomas that have been misdiagnosed as hemangiomas, and the opportunity to actually cure the lesion has long passed by the time the correct diagnosis is made. So anything atypical should be imaged. Anything that continues to grow beyond the 9-month period is not a hemangioma until proven otherwise.
Very important. Now, I might sound a little dumb, but there's a syndrome called FACES, P-H-A-C-E-S. So what is FACES syndrome, and should every patient with a facial segmental hemangioma be investigated for it?
FACES syndrome is an acronym, and the acronym stands for, the P stands for posterior fossa hemangioma, the H is hemangioma, which is usually a segmental hemangioma, the A for an arterial abnormality, the C for a cardiac abnormality, the E for an eye abnormality, and the S for a sternal cleft. So there's this constellation of abnormalities called FACES syndrome, which is associated with children with segmental hemangiomas. And about 30% of children with segmental hemangiomas will have FACES syndrome. So if a child presents with a segmental hemangioma, this child should be investigated for FACES syndrome. And you can imagine what investigations are necessary based on the abnormalities that are associated with this.
Very nice. Thank you. So, Teresa, Dr. O, how do congenital hemangiomas differ from infantile hemangiomas?
Well, both are vascular tumors, but that's really where the similarity ends. Infantile hemangiomas are generally not present at birth, and their hallmark is that they proliferate during the first few months of life up until about 8 to 10 months. They then enter a quiescent phase and then involute. Infantile hemangiomas are also GLUT1 positive, while congenital hemangiomas are not. Congenital hemangiomas, on the other hand, are always present at birth. And there are two types of congenital hemangiomas which are mentioned in this chapter, rich and niche. So rich stands for rapidly involuting congenital hemangioma, and niche stands for non-involuting congenital hemangiomas. Riches are fully formed at birth, and they start to involute after birth up until about 1 year of age, while the niches do not involute. In terms of treatment after involution, any atrophic skin or soft tissue defect, this can be treated surgically with excision or fat injection at times. The niches do not involute, and these require surgical excision.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
This is Sujana Chandrasekhar. Today I'm speaking with Drs. Teresa O. and Milton Weiner about the February 2018 issue of Otolaryngologic Clinics of North America, which is on congenital vascular lesions of the head and neck. I really appreciate the attention that was given to the psychosocial impact of vascular anomalies on children and their families. Teresa, Dr. O, when are these psychological manifestations likely to become manifest?
As mentioned in this article, Tanner and colleagues reported that children with infantile hemangioma are aware of a lesion being present by 18 months of age. They then can perceive themselves as different by 4 years of age. Children in general develop a sense of self by age 2.5 to 3. And by age 7, parents are beginning to note impaired physical, psychological, and school function. So we therefore recommend intervention by preschool age or even earlier.
Thank you. How we measure ourselves is really important. In all aspects of medicine and surgery, we're urged to develop validated outcome measures to gauge our interventions. So both of you, along with Drs. Horbach, Rongen, and Vanderhorst, address this issue in your article. Dr. Weiner, why has it been so difficult to come up with a single agreed-upon validated outcome measure in the field of vascular anomalies?
The short answer again, Sujana, is that we're comparing apples and oranges. Essentially, the treatment of these conditions has been undertaken by several groups. Interventional radiologists would embolize or sclerose, surgeons would cut these lesions out, and hematologists would be looking for the magic pill to take care of these lesions. And so each of these groups had their own specific outcome. What was good to an interventional radiologist may not look so good to a facial plastic surgeon, and vice versa. I may operate on a patient who looks good, but an interventional radiologist will say, hey, there's still tons of disease there. So we all had our own outcomes that we measured, but we never spoke to each other. So now for the first time, we're speaking to each other, and we're looking at outcomes based on whatever treatment is being offered.
And do you see buy-in from these sort of disparate groups, disparate interventionalists?
Yes, because we all get together and meet once a year or once every other year, and there has been a need. There's much discussion, and there's definitely a need for outcomes measurement. What typically happens is an interventional radiologist will show a series of before and after radiographs, and they'll look very good. A surgeon will show before and after surgical pictures, and they too will look good. So we're now agreeing on what a good outcome should be. And more recently, there's medical therapy, sirolimus, rapamycin. What should the outcome be? So we're starting to talk to each other, and we're starting to agree on appropriate outcomes.
Given that there are all these different types of interventions, what's the role, what's the timing of surgery for infantile hemangiomas? Since all of them involute, why would one consider intervening? Teresa?
Involute really simply means to shrink. It doesn't mean that the lesion will completely disappear and leave normal anatomy in its wake. It's really not magic. So infantile hemangiomas in anatomically sensitive areas like the nose, the lip, the eyelids will definitely distort the anatomy as it grows. It stretches the muscle fibers, it displaces normal fat and collagen, and it thins the skin. Function may also be affected. For example, a 1 centimeter mass on the upper eyelid is very different from a 1 centimeter mass on the back. The mass effect on the cornea can lead to astigmatism and amblyopia. And here we really don't have the luxury of time, of waiting and seeing what the medication does. A nasal tip lesion will displace the nasal cartilages outwards and backwards, leading to a bulbous tip. So in places where the anatomy is delicate or function is threatened, it's really necessary to intervene with medication and sometimes with surgery.
Milt, Dr. Weiner, I really enjoyed your article and the pictures regarding surgical management of infantile hemangiomas. Can you explain to our listeners what is the tissue expander effect and how can we best utilize it for the patient's advantage?
So the tissue expander effect takes advantage of the expansion of skin caused by the hemangioma. So this means that you can go in and remove the hemangioma and use this expanded skin to close the defect. As the hemangioma starts to shrink and involute, we lose this tissue expander effect. And so our ability to close the defect is much more or severely affected by the loss of the tissue expander effect. So the tissue expander effect simply refers to the ability of the hemangioma to expand the normal surrounding skin in such a way that once the hemangioma has been removed, the skin can be used to close the defect. So it acts pretty much like a skin expander. But we lose this once the hemangioma starts to shrink. So therefore, the optimal time to remove the lesion is when the lesion is fully expanded.
A separate issue in the management of infantile hemangiomas is the airway. And there's a really nice article by Dr. Darrow with a very helpful flow chart in the article regarding hemangiomas of the airway. Teresa, how do focal and segmental airway hemangiomas differ, and what's a subglottic hemangioma?
Well, just as background, Milton Weiner first noted that facial hemangiomas occurred in non-random sites of predilection, and that their distribution was focal or segmental on the face. Similarly, we found that airway hemangiomas were also focal or segmental, and this distinction is very important. Up to 60% of patients with V3 or beard distribution hemangiomas will also have airway involvement. And so children with this pattern should be scoped in the office or in the operating room. And recognizing this difference is also important because it predicts how the airway lesion will behave and what treatment we should offer. Both focal and segmental lesions are initially treated with beta blocker therapy, such as propranolol. And however, compared to the past, children rarely need trachs anymore. In the case of focal lesions which are obstructing, we use laser or excision as well as the medical therapy. And a subglottic hemangioma is really a good example of a focal airway hemangioma. Segmental airway hemangiomas usually respond well to medical therapy alone and rarely need any associated laser or surgery.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
This is Sujana Chandrasekhar, and I'm speaking with Drs. Teresa O. and Milton Weiner about the February 2018 issue of Otolaryngologic Clinics of North America, which is on congenital vascular lesions of the head and neck. So let's shift gears and speak a little bit about lymphatic malformations. The article by Perkins takes us into the future. Milt, Dr. Weiner, what is the new frontier in understanding head and neck lymphatic malformations?
The new frontier is understanding the genetics, because once we understand the gene abnormalities and the various pathways that lead to lymphatic malformations, we're going to be able to treat them medically. Now, we already have rapamycin, which targets the mammalian target of rapamycin, which is the mTOR pathway. And we know that rapamycin will shrink some lymphatic malformations. So the new frontier is genetic understanding and medical therapy. Now, in the olden days, all we ever did was sclerose them or excise them. Now we have a third option. We have medical therapy. But the truth of the matter is that medical therapy, the way it is now, is not the be-all and end-all. And we're still going to be gainfully employed as surgeons or interventional radiologists. But the frontier is understanding the biology and eventually coming up with the magic bullet, as it were.
Terrific. So both of you, Dr. O and Dr. Weiner, authored the article on multidisciplinary approach to the management of head and neck lymphatic malformations. And as an aside, having had the pleasure of working nearby you and seeing how you run your program, I think you do it extraordinarily well. Sometimes that word, multidisciplinary, just seems like a buzzword that appeals to administrators, but you really highlight the importance in these cases. So, Dr. O, can you describe this approach to the management of a patient with a lymphatic malformation and explain why we need it? And does this limit care of these LMs to tertiary specialty centers or at least the care of larger or more complex ones?
Sure. Since so many modalities are used, we really believe that a multidisciplinary approach will give the best outcomes. The first decision that really needs to be made is what form of treatment or treatments is necessary for a particular case. Will this child need sirolimus? Will this child need surgery or scleral therapy? A true multidisciplinary team will make the best decision. For example, a child with a cheek, neck, and airway lesion may initially be treated with the tracheotomy and medical therapy such as sirolimus. Then we would continue with scleral therapy and surgery for the cheek and neck areas. And at some points, we may treat the airway with directed scleral therapy via laryngoscopy approach. A small focal lymphatic malformation, however, might be treated with either scleral therapy or surgery alone with a good outcome. Regarding your question about tertiary specialty centers, if possible, I do think that a specialty tertiary care program is best. We have to remember that lymphatic malformations are rare at 3 to 5 per 100,000 births, and that the average otolaryngologist doesn't have much experience treating these patients. But this doesn't preclude an individual otolaryngologist who feels comfortable from giving treatment.
Venous malformations of the head and neck likewise need a multidisciplinary and a stepwise approach, as described in the article by Sarant, Vikula, and Boone. Dr. Weiner, can you talk us through some of the key points in this article?
Yes. Once again, a multidisciplinary approach is important. And the reason for this is if you have a hammer, everything looks like a nail. So if you're a surgeon, you're going to want to excise everything. If you're an interventional radiologist, well, you can embolize or sclerose whatever comes in. The answer is that both of these modalities are important. The trick is to find the right modality for a particular lesion at hand. And nowadays we also have medical therapy. And so what we do is if we presented with an extensive venous malformation, we will initially have the child's lesion sclerosed, which will render it bloodless. And then we'll go in and excise the lesion 24 or 48 hours later. For a very small lesion, we may just sclerose it or even excise it. And for a very extensive lesion with lots of symptoms, we may initially elect to treat medically. So it depends on the location of the lesion, the anatomical extent, and the extent of the lesion itself. And the appropriate treatment should be chosen. So a multidisciplinary team would be best to select therapy for a given lesion.
Can you talk to the risk of disseminated intravascular coagulation or other type of complication from any of these treatments?
Yes. there is a condition called localized intravascular coagulation, LIC. So what this means is that the venous malformation is an abnormality of veins, and there is chronic consumption going on within the venous malformation all the time. And so if you look at these patients, their profile is going to be abnormal. The D-dimer, the fibrin degradation products, etc., are going to be abnormal. So if we come along and sclerose the patient or surgically remove a malformation, we're going to upset this balance. We're going to suddenly push them into a crisis, and this crisis is known as localized intravascular coagulation. So it's the same as disseminated intravascular coagulation, but it's occurring in a localized fashion. It's occurring within the area of the venous malformation. And this is very important because left untreated, these patients can get into tremendous difficulties. And so it's important to recognize it and to treat it. And we treat it with Lovenox or low molecular weight heparin.
Okay, thank you. So we've talked about infantile hemangiomas, we've talked about lymphatic malformations, we've talked about venous malformations, and maybe we can move on to AVMs. So arteriovenous malformations of the head and neck are yet another entity that need individualized evaluation and care. In the article by Rosenberg, Suen, and Richter, there's a very nice table 1, which shows the classification systems for AVMs. Very useful if you're studying for your boards, for example. Teresa, Dr. O, can you briefly tell us how AVMs are different from LMs and VMs, and what should the otolaryngologist be aware of in the different management of these lesions?
Well, first of all of these lesions, AVMs, LMs, and VMs, are vascular malformations, which are different from vascular tumors such as the infantile hemangiomas. AVMs in particular are high-flow lesions, and this is because the capillary bed between an artery and a vein is abnormal. We believe that the problem is at the level of the precapillary sphincter, which controls the blood flow through a capillary bed. Over time, if you imagine, the vessels start to dilate and enlarge and can lead to congestive heart failure over time. A diffuse AVM is not compatible with the normal lifespan, and at this point, patients can have life-threatening bleeds. Lymphatic malformations and venous malformations, on the other hand, are low-flow lesions. Lymphatic malformations arise out of abnormal lymphatic vessels, and these prevent the normal production of or outflow of lymph in an area. Venous malformations are comprised of abnormal veins, as Dr. Weiner has discussed. The management of each of these lesions is again multidisciplinary. For AVMs, we perform surgery, usually preceded by embolization. And in LMs and VMs, we use a combination of laser, of surgery, and of sclerotherapy. So our goal for all of these patients, especially patients with diffuse disease, is to improve quality of life. And although possible for focal lesions, rarely are diffuse lesions cured.
So as we go from large vessels to capillaries, the article by Li and Chung on port wine stains talks about these in detail. So Milt, Dr. Weiner, what's the mainstay of treatment for the port wine stains?
Port wine stains are best treated with laser. A pulse dye laser is the laser of choice and the gold standard for treating port wine stains. Now, there is a role for surgery because the port wine stains appears to be a segmental abnormality, and a percentage of these patients will have a growth signal abnormality, which means that the tissues involved, not just the port wine stain, which is on the surface, but the underlying tissues will continue to grow and become hypertrophied. This growth signal abnormality appears to be as a result of an absence in the signal to stop growing. So as the child slows down his or her growth rate, the tissue affected by the port wine stain will continue to grow and just get bigger and bigger and bigger. And this happens throughout the life of the person. And so surgery will aim at correcting this. We'll remove big, large segments of tissue and try and reestablish facial symmetry. But we need to know that the process is ongoing. So 5 or 10 years later, we'll just simply have to repeat this. Now, once we know the genetic abnormality, we're going to be able to target this genetically and stop it so that when we do correct it, we will be able to prevent it from reoccurring.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
This is Sujana Chandrasekhar. I'm speaking with Dr. Teresa O and Dr. Milton Weiner regarding the February 2018 edition of Otolaryngologic Clinics of North America, which is on congenital vascular lesions of the head and neck. Dr. O, you and Dr. Klosterman have a really nice article on the management of airway vascular malformations. And I have to tell you that as an otologist, one or two of those clinical pictures in this article are pretty frightening. Are there patterns regarding airway vascular malformations? Is there a difference in how you treat the different types of those lesions?
Yeah, there are patterns. Dr. Weiner and I first noticed that all vascular malformations could affect the airway and that each had a unique pattern of involvement. We started by first studying infantile hemangiomas. Milton Weiner had made the discovery that these cutaneous hemangiomas occurred in non-random sites of predilection. And as we studied the airway hemangiomas, we found a similar pattern, that they were focal or segmental. And we found that it was really important to recognize this difference because it predicted how the airway lesion would behave and what treatment we would offer. Both are initially treated with medical therapy with beta blockers and steroids at times. In the case of focal lesions, which are obstructing, laser excision is also used. The subglottic hemangiomas are focal, but we have to remember that not all airway hemangiomas are subglottic, because I think that's a misnomer. People think, airway, it must be a subglottic hemangioma. But that's really not the case, that there are these different types of airway hemangiomas, which are either focal, it could be subglottic, it could be lateral, it could be above the vocal folds, or it could be more of a stain, like a segmental hemangioma. So after we looked at airway hemangiomas, we also started to see a pattern in airway lymphatic malformations. And so when we studied these, they also had a pattern of distribution in that they only involve supraglottic structures. And I think this is important because we know that once we can clear the supraglottic disease, the patient can be decannulated and have a normal voice. The glottis, the vocal folds, and the subglottic areas are always normal. And lately, we've been treating these lesions with laryngoscopy and sclerotherapy. Another kind of vascular malformation in the airway are the venous malformations, and these can affect all the levels of the airway, the supraglottis, the glottis, and the subglottis. For these lesions, we use a combination of sclerotherapy and laser treatment and have been very successful in, again, decannulating these patients as well. AVMs of the intrinsic airway are extremely rare, and in our practice, we have never seen one. So each of these vascular malformations does have a specific pattern of distribution in the airway, and it's important to understand this because this can guide the treatment.
Thank you. I think, Dr. Weiner, you alluded to the alteration in skeletal structures that you can see after the patient is diagnosed with what appears to be a superficial lesion. So can you just dive into that a little bit more for us? How do vascular malformations affect the facial skeleton?
Vascular malformations affect the facial skeleton in two possible ways. The first would be overgrowth, meaning that the vascular malformation has caused the bone to grow in an excessive fashion. And the second would be a mass effect. The mass effect meaning some big tissue mass which has molded the bone and caused the bone to grow in an abnormal pattern. So for lymphatic malformations, most of the bony abnormalities are a mass effect. For something like a port wine stain with tissue overgrowth, we also see that overgrowth in the bone. So for instance, some of them will have, if the V2 segment is involved, will have maxillary overgrowth. They'll have a bite abnormality or canting of the maxilla. And so this is a tissue overgrowth or an example of overgrowth. We also see arterial venous malformations causing tissue overgrowth or bony overgrowth.
It's interesting to me that I think when you look at categorizing these, you can really predict what the depth and what the extent of the lesion will be. If we go now from the facial skeleton to the nose, I think every single otolaryngologist has experience dealing with severe epistaxis in hereditary hemorrhagic telangiectasia. There's an article here that goes through the international guidelines for treatment regimens depending on clinical manifestations. Dr. O, what are some of the newer treatments that the otolaryngologist should be aware of for HHT?
Well, currently there's still no cure for HHT, and there isn't any great medical therapy, although medical therapy is sort of the future. Currently, we have tranexamic acid, which is the only medication specifically approved for HHT. It's an antifibrinolytic agent and promotes clotting. We have N-acetylcysteine, which seems to reduce epistaxis, especially in males with type 1 HHT. That's the endoglin defect. And both of these meds are really well tolerated. Patients may report decreased bleeding by about half of what they normally experience. Another class of medications includes the VEGF inhibitors. Avastin is an FDA-approved medication, or bevacizumab is one of the most commonly used medications. It has to be taken orally. They've tried topical versions which have not shown much efficacy. However, we have had some efficacy with submucosal injection in combination with YAG laser treatments. It seems to increase the interval between laser treatments, and patients seem to have subjective benefit. There are other VEGF inhibitors currently being studied as well. There are mTOR inhibitors. Milton's spoken about sirolimus for other vascular malformations. This has also been reported in the literature for HHT. But I do have to say that one of the mainstays for nasal epistaxis in HHT still should be laser treatment, which is very targeted and specific with a combination of submucosal injection of either VEGF inhibitors or other sclerosants.
Thank you. And finally, the last article in this really terrific compilation of articles that you two have put together is by Persky and Tran on acquired vascular tumors of the head and neck. So not congenital lesions, but acquired lesions. These are pretty rare, less than 5% of all head and neck tumors. I have to say to you, I trained with Dr. Persky in my residency, when wheels were square. And And I think the management has really changed in this time period. So, Dr. Weiner, can you tell us what we need to know about the current management of paragangliomas and then juvenile nasopharyngeal angiofibromas?
As far as juvenile nasopharyngeal lesions are concerned, the JNA, juvenile nasopharyngeal angiofibromas, the surgical approach or the approach to the management of these lesions is surgical. We've moved away from big open procedures to endoscopic procedures, but clearly we can only do endoscopic procedures if the extent of the lesion is limited and it lends itself to this. Preoperatively, these patients will be embolized and this will reduce intraoperative blood loss. Radiation therapy is used in these patients, but only for very extensive lesions or for lesions that have recurred. As far as the other lesions are concerned, the head and neck paragangliomas, we've moved away from surgical resection of these lesions to observation. And this is somewhat surprising, but really shouldn't be, because these are so slow growing. Their growth rate is so indolent that unless you suspect something or something is not going according to plan, we can afford to watch and wait these lesions. We will resect a small carotid body tumor that's less than 5 centimeters in diameter, but for a very large lesion or something greater than 5 centimeters, it's been found that observation is probably the best thing to do. One should read this article because Drs. Persky and Tran have really done a fabulous job of highlighting the different lesions and their approach to each and every one of these lesions. But suffice it to say that we've moved away from aggressive surgery to observation.
Again, our own obsolescence approaches us, right?
Unfortunately.
Or fortunately, we'll come up with something else to do, I'm sure.
I hope so.
This is Sujana Chandrasekhar. I've been speaking with Dr. Teresa O and Dr. Milton Weiner about their February 2018 issue of Otolaryngologic Clinics of North America on congenital vascular lesions of the head and neck. Teresa and Milt, I want to take this opportunity to congratulate you both on assembling what I think is the authoritative reference on these lesions. You've covered every bit of this topic in detail, but each article is accessible and easy to read and understand with the right amount of tables and images. I hope that both practicing otolaryngologists as well as trainees take the time to go through it and to share the salient articles with their pathology and radiology colleagues. You, the reader, can go to www.oto.theclinics.com